Welcome back to the deep dive. For medical professionals like yourselves, the speed at which global healthcare is changing is, well, it's just breathtaking.
It really is.
And few sectors show this shift better than medical tourism. It's moved so far beyond being just a footnote. It's now this highly structured global industry. And it fundamentally influences how resources are allocated. It brings up serious ethical questions. And I think most critically, it impacts patient safety on a global scale.
Indeed. And for those of us working within, established, often nationally focused health systems, we really can't afford to treat medical travel as some kind of periphery issue.
Right.
It represents both a massive competitive market force and an increasingly necessary area for global governance and standardization.
So mapping this all out means tackling some huge complexities. Our mission today is to go beyond the big headline numbers and really explore the mechanics of this ecosystem. We need to identify the key players, from the destination hospitals and the insurers holding the purse strings, right down to those often overlooked intermediary roles. We have to understand precisely how quality is assured and how risk is managed when a patient crosses a border for major surgery.
And that's the absolute core of the issue. The modern medical tourism industry is defined by this really intricate balance, what I often call a constant synergy and tension among these incredibly diverse actors.
Synergy and tension, I like that.
The rapid growth we've seen isn't an accident. It's the result of these powerful combined shifts in health policy, global economics, technology, and even just travel. For us to maintain the highest standards of care, understanding this deep interdependence is key.
Okay, so let's really unpack this structural shift. I mean, we all hear about cost being the main driver for patients going overseas, especially from, the UK or the US.
Right.
But what are the deeper systemic conditions that allowed this market to flourish? What are the policy failures really pushing patients out?
Well, it really is a classic market dynamic, but you're right to look deeper. It's driven by some pretty profound structural healthcare failures and policy choices in those developed nations.
So not just about saving a bit of money.
Not at all. And the best way to think about it is in terms of push factors, so what's driving the patient away,
Yep.
and then the pull factors, which are, what's attracting them to a new destination.
Okay, let's start with the push. From your perspective, what are the big policy decisions that have created this constrained environment in the origin countries?
The primary push factors, really, they stem directly from this global wave of neoliberal healthcare reforms over the last few decades. We've seen aggressive privatization, we've seen sustained budget cuts to public health services, and the result is a reduction in comprehensive coverage in many of these economies. This shift has placed a massive financial burden directly onto the patient. We're talking escalating out-of-pocket costs, high co-payments, ever-increasing deductibles.
So even if you have insurance, you're still facing a huge bill.
A huge bill. And when access to a necessary but high-cost orthopedic procedure becomes heavily marketized, it forces a big segment of the population to start looking globally for an affordable option.
So it's not just the sticker price of the surgery itself, it's all that financial friction of navigating a system at home.
Precisely. And that friction is then compounded by capacity constraints.
The waiting lists.
The waiting lists. The 12 to 18-month wait for a quote-unquote non-urgent hip or knee replacement.
Yeah.
The months-long queue for specific cardiac interventions. This creates enormous and often very painful unmet demand.
I read one summary that put it perfectly. It called medical tourism a makeshift solution to the escalating waiting lists and exorbitant costs.
That's a perfect summary because if a patient who's often in significant chronic pain has the choice between waiting 2 years at home or flying next month for the same procedure at a third of the cost, well, the market incentive is just overwhelming, isn't it?
It is. And that structural failure at home creates a vacuum that developing nations are now actively and very strategically filling. So what are the key pull factors? What's attracting patients?
Well, the destination countries are highly intentional about this. They see medical travel not just as another revenue stream, but as a critical part of their national economic development strategy.
So this is state-level planning.
Absolutely. They aren't just passively waiting for patients to show up. They are funding strategic public-private partnerships. They're investing in infrastructure and coordinating these really aggressive promotion campaigns targeting international markets. This is economic statecraft.
And I suppose those logistical barriers that used to protect domestic markets, the difficulty and cost of international travel, have been systematically dismantled.
Completely. They've been drastically lowered by huge improvements in travel facilitation. We've seen the boom in low-cost international carriers, which just immediately reduces the financial barrier of the flight. And crucially, governments in these destinations are streamlining the regulations. They're offering specific medical visas, sometimes with priority processing or even visas on arrival. And they often bundle the medical care with tourism packages. So, high-end hotels, dedicated transport, even tours for the family.
It makes the whole thing feel less like a daunting medical trip and more like a structured, high-value service package.
That's exactly the goal, to reduce the psychological barrier as much as the financial one.
And the final factor, which has to be the most revolutionary, is the complete democratization of health information through technology.
Oh, absolutely. Digital empowerment has revolutionized the entire patient journey. The internet lets patients completely bypass the traditional gatekeepers, their GP, their insurer's restrictive list. They can now conduct their own global health searches.
You see these powerful online portals, comparison sites, apps.
Right. And they provide this astonishing, if sometimes a bit misleading level of transparency on pricing. A patient can compare costs for a very specialized procedure across dozens of accredited hospitals around the world. They can read detailed peer reviews and even have virtual consultations with international specialists.
So that free flow of information boosts patient confidence enormously. They feel like they're making a data-driven decision.
They do. It moves it from a leap of faith to what feels like a calculated choice.
Can you give us a practical example of how this coordinated government strategy using these digital tools actually works on the ground?
The Dubai Health Experience, or DXH platform, is probably one of the most compelling examples out there. This isn't just a hospital website. It's a powerful government-sponsored initiative driven by the Dubai Health Authority.
I see.
The platform actively promotes and aggregates hundreds of Dubai-based hospitals and clinics. It showcases their specialist services, their accreditation status, their treatment packages, all to a global audience. And the results are, well, they're significant. Dubai has successfully attracted nearly 700,000 health tourists a year.
700,000.
It's positioned itself as a major, reliable global hub. And that coordinated model shows how strategic policy, aggressive investment, and smart digital marketing all work in concert to create this self-sustaining ecosystem.
That's a fascinating insight. So, to summarize where we are, we have these powerful economic pressures and frustratingly long waiting times pushing patients out of established systems. Coupled with the sophisticated pull of lower prices, modern facilities, logistical ease, and this digital confidence offered by countries that have strategically decided to invest in medical travel as a key economic asset.
That's the core summation. And these economic, logistical, and digital trends are all mutually reinforcing. They're creating this persistent structural pressure on health systems right across the developed world.
Now let's shift focus to the ground floor, which I think is absolutely critical for our clinical audience, the destination hospitals themselves. How do these facilities differentiate what they offer clinically, and what verifiable standards should a UK or US-based professional look for if they're, say, coordinating follow-up care for a patient?
Well, differentiation it's existential for these facilities. It's a hyper-competitive international market.
Of course.
So these destination hospitals, which are typically large, private tertiary care centers in places like Southeast Asia, the Middle East, or Latin America, they primarily compete through massive investment in quality infrastructure.
And what does that investment look like?
It's twofold, really. Firstly, technology. They often acquire state-of-the-art equipment. We're talking the latest generation of robotic surgery platforms, advanced 3D imaging suites, things that may actually be newer than the tech available in many public sector hospitals back in the patient's home country.
So they're competing on having the absolute latest.
They are. And secondly, they invest very heavily in human capital. Specifically, they recruit Western-trained, multilingual specialists who have all the relevant international qualifications. This directly appeals to that international clientele's desire for familiar expertise.
But that branding has to be backed up by tangible proof of quality that works across borders, doesn't it?
Yeah.
Which brings us to the crucial role of international accreditation.
Absolutely. For a foreign patient, trust can't be based on a national system they don't understand. It has to be built on verifiable external validation. And the single most influential way to establish that trust mark globally is through international accreditation.
And specifically the Joint Commission International, or JCI.
That's the one. JCI accreditation is universally adopted. Hospitals that achieve it proudly display the gold seal of approval. It signals to patients, and just as importantly to insurers, that the institution meets these rigorous, externally audited patient safety and quality benchmarks.
So JCI is essentially the common safety language for the whole ecosystem. It standardizes processes across all these different legal jurisdictions. What does a JCI audit actually look at in clinical terms?
JCI's focus is on the process that underpins quality, not just the final outcome. Their standards cover dozens of crucial clinical and operational areas. So that includes mandatory adherence to international patient safety goals, like proper site verification and timeout protocols before surgery, which is absolutely non-negotiable for orthopedic procedures.
Right.
They audit rigorous medication reconciliation processes. They mandate robust infection control protocols, covering everything from instrument sterilization to the hospital's architectural design. And the reaccreditation cycle, which happens every 3 years, ensures that rigor is maintained.
So standards can't slip after the initial approval.
Exactly. It forces continuous improvement.
And can you give us some examples of hospitals that have really successfully leveraged this JCI status to build their brand?
Oh, certainly. This strategy has created regional powerhouses. Bumrungrad Hospital in Thailand was one of the first major pioneers. Facilities like the Prince Court Medical Center in Malaysia have followed that model.
I've heard of both of those.
By achieving and consistently maintaining their JCI accreditation, they've built these reputations that specifically attract high-spending international patients, establishing themselves as top-tier clinical hubs.
And are there other standards to look out for?
Yes, while JCI is dominant, other standards are relevant in certain markets. You might see Accreditation Canada International, or the NABH in India, or the more general ISO 9001 certification. For any medical professional advising a patient, checking for one of these recognized accreditations is the absolute minimum baseline of quality assurance.
That focus on quality and international standards is clearly a major positive. You could argue it raises the bar for the host country's entire health system. But focusing so heavily on the lucrative international market must create some internal friction. I wonder, is the brain drain argument against medical tourism actually valid? Does it siphon off the best talent and resources?
That is the core ethical and operational tension that these destination countries have to manage. And the critics are right to warn that catering primarily to high-paying foreigners can lead to a diversion of essential resources.
So things like a surgeon's time or access to that new robotic platform.
Exactly. Or even just dedicated nursing staff. They can all be diverted away from local public health needs. This can create what's called an internal brain drain, where the most experienced clinical talent moves from the public sector to the much more lucrative, private, international-focused hospitals.
And that would just exacerbate existing health equity issues for the local population.
It can, yes.
So, high standards for the global patient, but potentially reduced capacity or access for the local one. How are host country regulators starting to manage that inherent conflict?
It requires a highly sophisticated and evolving role for the host country regulators. They're under increasing pressure to implement policies that monitor and manage capacity usage.
For instance,
some regulators now require private hospitals to dedicate a minimum percentage of their capacity or their specialist time to local residents. Or they have to demonstrate a continuous commitment to training local staff in exchange for the right to serve international patients.
I see.
The goal is to ensure that while international standards are raised across the board, domestic health needs are not neglected. And this requires robust national licensing and audit requirements that operate alongside the international accreditation systems like JCI to enforce that delicate balancing act.
Right. Overseeing medical care in a foreign country, it's just inherently complex. This brings us to that crucial middle layer, to the facilitators. What specific specialized roles do these intermediaries play in ensuring a smooth and clinically safe patient journey?
The facilitators are essential, but they're often the least regulated part of the whole process. They are the private agencies and case managers who form the critical middle layer of the medical travel value chain. Their core function is really clinical, logistical, and cultural translation. They translate a foreign patient's complex needs into coordinated care delivery in the host country. Without them, the system would be chaos.
So what are the distinct professional roles within this sector? I imagine it's not all the same job.
No, you typically see 3 main tiers. First, you have the medical travel coordinators. You can think of them as specialized travel agents. Their focus is pure logistics, arranging flights, securing visas, booking appropriate lodging, often post-operative recovery suites, and managing the hospital scheduling.
So they're laying the crucial groundwork. But the real expertise comes in when the process moves to clinical accountability.
Precisely. This is where the medical case managers come in, and this role is the most fascinating and critical for quality control. What's fascinating here is the clinical depth required. These professionals are typically drawn from strong clinical backgrounds, often nursing or social work, and they oversee the patient's entire clinical journey,
The entire journey.
from start to finish. They're responsible for explaining complex treatment options in a culturally sensitive way, ensuring coordination between all the different providers, and, crucially, managing and tracking the often challenging follow-up care that will be needed once the patient returns home.
That sounds like an extremely high-stakes role. It must require recognized clinical and ethical standards far above that of a travel agent. Is there a push towards professionalizing and credentialing these case managers?
There is, and it's a very positive sign of market maturity. The Certified Case Manager, or CCM, credential from the Case Management Society of America, CMSA, is becoming highly recognized internationally.
The CMSA.
Yes, it provides a framework for training and sets rigorous standards for patient advocacy and care coordination. Having a CCM-qualified case manager involved means you have a professional who can liaise with surgeons, verify surgical plans, ensure detailed discharge documentation is properly secured and transmitted. It's a vital mechanism for raising the professionalism of this rapidly emerging occupation.
And then, at the highest end of the market, you have services dedicated purely to convenience and comfort.
Those are the destination concierges. Their role is to attend meticulously to all the non-medical needs, often as part of a premium package. They'll manage luxury post-operative hotels, arrange specialized transport, handle restaurant reservations that fit dietary needs, and even organize low-impact leisure activities after recovery.
They make the experience seamless.
Exactly. It reduces stress, which is conducive to a faster, less complicated recovery.
While professionalization through bodies like CMSA is encouraging, the sector is still inherently challenging because there isn't a single overarching international regulatory authority, is there?
That remains the major governance gap. Facilitators are still largely unregulated by specific government bodies globally, and this lack of oversight has led to some legitimate and very serious concerns.
Such as?
Misleading advertising, wildly inflated claims about success rates that have no objective data behind them, and, in the most concerning scenarios, non-clinical staff giving unsound medical advice just to secure a commission. This is where the patient is most vulnerable.
So how is the industry attempting to self-regulate to close this gap?
We are seeing emerging attempts at professional oversight. The Medical Tourism Quality Alliance, MTQUA, for example, is an organization that certifies facilitators based on specific ethical criteria. And more broadly, best practices now demand mandatory transparency.
What does that look like?
It means facilitators must clearly disclose all their fees, openly and accurately communicate surgical risks, and secure explicit patient consent for sharing medical information between providers. Competence and ethics in this middle layer are absolutely vital.
Moving beyond the immediate point of care, we have to consider the systemic drivers, the organizations that control the money and set the rules: insurers, large employers, and governments. How are these groups shifting from being observers to active demand shapers?
The involvement of large payers, insurers, and massive self-insured employers is what truly legitimizes and scales the industry. Historically, medical tourism was a purely out-of-pocket thing.
Right, for the wealthy or the uninsured.
That dynamic has changed fundamentally. Facing ever-increasing domestic costs, large U.S. employers and health insurers are now actively offering plans that incentivize or even mandate overseas treatment for specific, expensive, non-urgent procedures.
And I imagine this is a purely fiscal decision driven by those huge cost differences.
It is a calculated cost-saving measure. Insurers are negotiating highly specific bundled rates for common procedures like hip replacements or spinal fusions with accredited foreign hospitals. These bundles are all-inclusive, covering everything from the surgery to the travel.
And the saving is significant.
Often 40 to 70% lower than the domestic cost. This allows the payer to pass on huge savings, often by eliminating copays or deductibles entirely if the patient goes abroad.
So these payers become powerful demand shapers because they hold the financial lever. By contracting selectively, they're setting the de facto quality standards, correct?
Precisely. They dictate the acceptable clinical environment. They set rigorous criteria mandating JCI accreditation, requiring specific clinical pathways for any foreign provider they'll work with. Their goal is cost savings, but their requirements inherently drive up quality standards in the market.
But there's a tension there.
There is. While their quality criteria raise the floor, their financial leverage can also be used to pressure providers for volume discounts, which can potentially put a strain on the facility.
And their biggest challenge has to be that risk of fragmented care, the continuity challenge.
That's the major risk they assume. Insurers have to coordinate coverage not just for the primary procedure, but for any necessary follow-up care and, critically, any complications that arise once the patient is back home.
That must require incredibly robust data sharing.
Exceptionally robust. And this is also why we've seen the emergence of specialized medical tourism insurance products. They're designed specifically to cover catastrophic complications that a standard health plan might exclude, creating a necessary financial safety net.
Let's pivot now to the regulators and governments. As you said earlier, they're operating with this profound, challenging dual mandate.
It is a significant governance challenge. On the one hand, governments and destination countries have to promote the industry. They see it as a major economic asset, and they set up bodies like the Malaysia Healthcare Travel Council to do just that.
And on the other hand,
They have a fundamental obligation to rigorously protect patients, both domestic and foreign, and to safeguard broader public health.
when governments need to set minimum standards for these facilities, how do they do it without building entirely new bureaucracies?
They cleverly use quality accreditation as a quasi-regulatory tool. Rather than developing their own inspection regimes, some countries just make third-party accreditation like JCI, a mandatory licensing condition for any hospital that wants to serve international patients.
So they effectively outsource the setting of minimum standards.
Exactly. It allows them to focus their limited regulatory resources elsewhere.
We're also seeing policy moves at the supranational level, aren't we? Particularly in Europe.
That's right. The EU Cross-Border Healthcare Directive from 2011 is a landmark example. It formalized the right of EU citizens to seek reimbursement for care they get in another EU country. While uptake has been a bit patchy, it codifies the principle of patient mobility across borders.
This raises an important question for every medical professional listening. What happens when the governance and quality control mechanisms fail? When the public health system back home has to absorb the fallout?
This is perhaps the most critical operational area for our audience. When standards lapse in a high-volume facility abroad, the consequences can become transnational and severe very quickly. The Pan American Health Organization, PAHO, has issued stark warnings after documented outbreaks.
What kind of outbreaks?
Things like dangerous fungal meningitis clusters or widespread gastrointestinal infections, all linked to procedures in facilities that had inadequate sterilization or infection control.
So what are the specific clinical implications of a patient returning with one of these infections acquired overseas?
The primary concern is the transmission of highly resistant organisms. We have seen documented cases of patients returning to the U.S. or Europe carrying carbapenem-resistant Enterobacteriaceae, CRE, or highly aggressive strains of MRSA.
Which are incredibly difficult to treat.
Incredibly. And they pose a massive containment risk for domestic hospitals. They might require isolation protocols, and they place this additional, often unseen financial and epidemiological strain on the home health system. These incidents really underscore that medical tourism isn't just a commercial transaction. It's a critical, complex public health concern.
For the clinician, managing a patient who has received care abroad presents these profound risks and ethical dilemmas. The primary clinical challenge, as you mentioned, is that continuity of care.
The risk of fragmented care is immense, and it's largely driven by data incompatibility. If a patient develops a delayed complication, say a loosening orthopedic implant or severe surgical site infection weeks or months after returning home, the transfer of their full medical record is often compromised.
EMRs that don't talk to each other, different report formats.
Precisely, and a lack of standardized implant tracking.
Implant tracking sounds like a specific nightmare for orthopedic specialists.
It is. Imagine needing to revise a hip or knee replacement. If the foreign facility fails to provide the precise manufacturer, model number, and lot number of the implant, which happens all too frequently, the home surgeon can't access the necessary instruments or conduct a proper failure analysis.
which leads to delays, increased risk, and a much higher cost domestically.
Vastly increased. We need a mandatory, globally recognized system for identifying and tracking these critical devices.
Beyond clinical safety, the ethical landscape has been a major focus, especially after some high-profile scandals.
It absolutely has. The industry has to adhere to clear, ethical cornerstones. The most prominent framework is the Declaration of Istanbul from 2008.
And what does that cover?
It specifically addresses and strictly outlaws the sale, trade, or trafficking of human organs, a necessary response to the dark practices of transplant tourism. And other professional codes are continuously updated to prevent misleading advertising and uphold fundamental patient rights no matter where the procedure takes place.
Even with good intentions, achieving genuine informed consent must be profoundly complicated by the high-pressure, international nature of the whole transaction.
It's a critical weak point. The reality is that significant language barriers, combined with cultural differences in how risks are communicated, can seriously complicate things. And this is often worsened by these highly commercialized online marketing claims, the promises of a perfect body or guaranteed success.
Which can inflate expectations.
Seriously inflate them and compromise the patient's sober understanding of the real risks. And this is compounded by emerging concerns over data security and privacy, as sensitive medical records cross international borders governed by often incompatible legal frameworks.
So if we connect this to the bigger picture, quality governance is clearly a shared responsibility. It demands collaboration across all stakeholders, from the surgeon in Thailand to the payer in London. How do we move towards systems that mandate that kind of transparency and accountability?
Collaboration is the only way forward. We have to shift the focus from merely ensuring process quality, which is what JCI does, to ensuring verifiable, long-term patient outcomes.
So what concrete steps are being suggested as best practices for the future to achieve this?
Firstly, from the provider side, we need the mandatory adoption of patient passport systems, standardized, concise, and digitally secure summaries of the treatment that was provided abroad.
What would need to be in that patient passport for it to be actually useful for the receiving physician?
For it to be truly useful, it needs granular, clinically relevant data. So clear contact info for the foreign QA office, the surgical summary, any intraoperative findings, exact details of medications prescribed, and crucially for orthopedics, mandatory digital stickers or unique device identifiers for all implanted materials.
So the home surgeon can immediately access revision plans.
Exactly. Secondly, the financial drivers, insurers, and accreditors, they must insist on mandatory tracking and sharing of international patient outcomes, including complication rates and long-term functional recovery scores.
Data that goes beyond marketing slogans.
Yes. And thirdly, the facilitators must continue to raise their professional standards, universally adopting certified training like the CMSA credential and offering detailed, transparent aftercare packages.
That holistic approach linking robust accreditation like JCI to certified coordination like CMSA and systemic tracking, that's where the industry has to mature if it wants to earn and keep global trust.
Absolutely. Responsible growth hinges entirely on aligning those powerful economic incentives with strict, auditable, ethical, and quality standards.
If you, as a medical professional, have found this deep dive into the governance and ethical tensions of medical tourism valuable, please consider rating and sharing the deep dive within your professional networks. So to recap our deep dive, we've established that medical tourism is this complex, integrated ecosystem. It's driven by profound economic push-pull forces, often stemming from policy failures and high costs at home. The clinical core is regulated by powerful accreditation bodies like JCI, and the patient journey is coordinated by specialized and increasingly certified facilitators.
And all of this operates under the watchful but dual eye of governments, trying to both promote the industry and protect their patients. Ultimately, as we said, success relies on aligning economic incentives with strict ethical and quality standards, all backed by verifiable data.
I agree. We've seen how digital platforms and online patient reviews have made medical consumers highly empowered. They can search and choose providers globally with incredible ease.
They can. Yet, despite this digital revolution, access to truly independent outcome data that goes beyond marketing claims and accreditation checklists, it remains elusive. It's fragmented. The current reliance on certifying processes is a necessary step, but it's not sufficient.
So what's the immediate, most challenging task for the global medical community as they look to the next decade of patient mobility?
The finer provocative thought is this. How can the medical community globally collaborate to establish mandatory, transparent, and comprehensive patient outcome registries that truly protect the mobile patient?
So something that tracks complications, implant failures.
Long-term recovery rates, irrespective of the country or the hospital's marketing budget. This transformation, from relying on market hype to mandating rigorous shared data reporting, that is the single greatest governance challenge for the medical tourism industry over the next decade.